My name is Mike Whitty. I'm a family physician and the Chief Medical Officer at the California Primary Care Association. I'm really happy to be able to introduce Dr. Jeff Rideout, the CEO of the Integrated Healthcare Association, based in Oakland but serving all of California. The Integrated Health Association represents many both commercial and also public payers in gathering data to be able to evaluate high quality and value in healthcare. Dr. Rideout has championed the concept of being able to access good data to be able to improve our care, both in our vulnerable populations in the safety net, as well as in other populations throughout California. One of the initiatives that the Integrated Healthcare Association has championed is the Provider Directory utility. This eventually would include all NPI numbers in the state of California. IHA has been working to develop this utility, which is now known as the Symphony Directory utility, and is rolling this utility out over the course of the next 18 months and more to be able to provide all of the health plans, both commercial and public in California, with a unified way of being able to reliably find all of the providers that are within the various networks in California.
Well, thank you, Mike, for that very kind introduction. I'm hoping I can share some of the tremendous enthusiasm we have both here at IHA and in the industry for what should prove to be a superior solution to the challenging problem of provider directory collection. Let me go over the learning objectives for today. First of all, I'd like everybody to hopefully understand the current challenges of managing provider data in California. I'm sure most of you on the front lines understand this all too well, and I had my own taste of it when I was the medical director at Covered California as we tried to consolidate information from multiple plan directories into a single format, which was very challenging and ultimately unsuccessful. Hopefully the Symphony Provider Directory will provide a better shot at making this work. Second, I'd like to have everybody appreciate how the Symphony Provider Directory model is different and supports the needs of providers first. So rather than have an efficient model that works for one health plan and one provider relationship, Symphony is designed from the start to essentially be a platform for multiple plans and multiple providers so that they can update their information once and have it be correctly distributed to multiple trading partners. Third, I'd like to also share some insights and baseline data from our provider directory soft launch that we just recently completed. And as much as this information is both challenging and frustrating, it also shows us exactly why the Symphony Provider Directory utility is so necessary in the industry. First of all, it's probably important to understand who the Integrated Healthcare Association is and why we're so in the middle of this challenge. First of all, somewhat of an inside baseball study of the tax code. We're actually organized as a not-for-profit, but uniquely as a 501c6. And by definition, that means we're a business league, and our sole purpose for existing is to solve business problems that exist across multiple trading partners that they themselves cannot solve on their own. So it's an interesting structure. There are very few 501c6s out there, and what also makes this an interesting format is our membership is quite diverse. It includes health plans, it includes risk-bearing provider organizations, it includes hospital systems, it includes academic medical centers, it includes academic institutions, it includes purchasers, it includes consumers. So if you think about the original charter of a 501c6 to find common solutions to problems that are shared across your membership, you can see that there are many, many challenges in finding common solutions that work across that many sectors of healthcare. I think the other thing that's important for people to understand is while we are not exclusively focused on any one business line or business sector, we do have strong representation from a number of organizations that are primarily or even exclusively focused on Medi-Cal. And that's important because what we find in our work is very often the interests of different sectors are quite different. And as I think most of us understand, the regulatory environment overseeing Medi-Cal versus Medicare and Medicare Advantage versus commercial actually is not only different, but is regulated by different organizations. And that plays into both the challenges and the opportunities with the Symphony Provider Directory utility. First of all, let me give you a lay of the land in terms of how complex the environment is for collecting and determining accurate the available provider information. First of all, according to AMA data, the average number of plans a provider contracts with can be 12, and we know in our own experience in California it can be much more. So first of all, you have 12 trading partners at a minimum, and likely each trading partner has a different process, different set of deadlines, a different way to collect the same type of information. So that creates a certain amount of complexity in and of itself, actually quite a bit of complexity. We also know that organizations that are involved in this, both on the plan and provider side, may have up to 7 full-time equivalents actually working just to get the information in and determine whether it's accurate or not. So now you have 12 plans and hundreds of provider organizations of various sizes and sophistication. Each one of them may be dedicating anywhere from 1 to 7 FTEs to do it. So it's an enormously inefficient way to collect information, and I'll show later on how inaccurate that information actually turns out to be. And what we know from the Medicare information is that nearly 50% of all online provider directories for Medicare Advantage organizations have at least one inaccuracy. Now that may not sound like a lot. The inaccuracy may be small. It could be huge. Provider location isn't correct. Provider specialty isn't correct. Provider isn't seeing new patients. So all of that feeds into a process where you have multiple systems, multiple processes, multiple trading partners, all with maybe a small number of inaccuracies themselves, but when multiplied together creates essentially chaos. And when I was the medical director at Covered California, we saw this for real as we tried to publish a composite directory that looked across multiple health plans, and essentially every error is amplified over and over and over again to the point where the directories themselves are pretty useless in terms of giving consumers accurate information. So if the state that I just described is represented on the left side, where every provider organization and every plan has its own process and turns into massive spaghetti, the state on the right-hand side is what we're shooting for. And it really is a relatively elegant and simple model in theory, where providers and plans each access a common utility that's collecting, verifying, and authenticating information, finding errors, going back to the individual source to correct the error that would apply maybe across multiple organizations, and then validating that information so that other parties, in this case represented by Covered California, for instance, can in fact draw from that information to get the most accurate directories available. This is also how a health plan would use the information. They would contract with multiple provider entities that are also contracting with other health plans, but they would rely on the Symphony Provider Directory, that utility function, as the single source of truth. So again, a relatively elegant model that any number of us can be thinking about. It's actually interesting that it's very, very consistent with the mission of IHA and, as I mentioned, the 501c6 charter of finding these types of administrative workflow simplification solutions. It's probably also important to note, as we talk about this model, it's not something that's wholly new. This actually came about as a result of the Department of Managed Healthcare requirements that Blue Shield fund a model such as I just described as a condition of their acquisition of Care First. So the roots of the funding for this and the roots of the challenge actually come out of the real world need to address this problem and the real world interest that Blue Shield had in acquiring Care First. So that goes back to 2015. There was actually quite a bit of work to create uniform standards, and it wasn't until 2017 that IHA was actually selected as, in a competitive bid process, I would add, as the organizing entity for the Symphony Provider Directory. What we see now as 2019 gets started is that we are now through our soft launch pilot phase successfully, and we are now into scaling this infrastructure for the entire state. So we've made fairly quick progress. We've made pretty thoughtful and diligent progress, but I do want to trace the roots back to 2015, which is where this concept actually started through the Department of Managed Healthcare. Now, I mentioned the Department of Managed Healthcare because it is one, but not the only one, of the major regulatory agencies that has a strong interest in accurate provider directories. So this slide actually represents the range of regulators that have statute and regulation related to provider directory accuracy, and from a provider organization's point of view, they might be regulated by one or even all of these organizations depending on what products they choose to offer and support through their network participation agreements. Obviously, the Department of Managed Healthcare regulates many of these entities, both on the Medi-Cal and the commercial side. The Department of Healthcare Services, which oversees Medi-Cal, also has its own and somewhat unique regulatory position on this. There are PPO products and self-funded products that are regulated by the California Department of Insurance, but not all PPOs in California are so regulated. Then there's also federal regulators through CMS for Medicare Advantage plans in particular. So there's a lot of people that have an interest. Unfortunately, each one of these boxes represents a somewhat unique approach to oversight and regulation of provider directory accuracy. So another one of the challenges in the utility environment we're trying to create is how to coordinate the regulatory environments as well as the health plan and provider information exchange environment. One thing I will point out as the highlighted box is Senate Bill 137. This bill was passed a few years ago in direct response to the challenges that emerged from inaccurate provider directories as the ACA took effect through Covered California. So this was a legislative response to what was perceived to be an wholly inadequate situation for consumers to understand availability of providers, both in terms of what providers were available when, what specialties were available to them through different plan products, and which ones were accepting new patients. For the most part, Senate Bill 137 drives much of the challenge, especially in California, because it has the most rigorous standards. And so one of the things that we've had to do with the Symphony Provider Directory is tune our work to the highest bar, which in general is Senate Bill 137. That's also the one that has the most penalties for plans and providers that don't comply, but we also had to do so in concert and in harmony with the other regulators that operate in California, because at the provider level in particular, all of these regulations and all of these plan relationships come to play, and for the most part, not in a good way. The other challenge I'd say is there are, and we find in our work, many dependencies on the providers themselves and many penalties that the providers themselves may be exposed to that, quite frankly, they might not be fully aware of. So one of the challenges is that providers are required by law to attest within a required time frame that the information provided to them currently by a plan is in fact accurate under penalty of either reduced payments or removal from the network. Now, to be perfectly clear, most of our plan partners say that that is a very, very difficult thing to even imagine, given the challenges of creating broad and sufficient networks, nor is it the kind of business partner relationship they want to implement. However, those are the regulations that are now on the books that are new, that are fairly draconian if they were in fact applied literally. So what we're trying to do with the regulators, quite frankly, is get ahead of the penalties associated with bills like Senate 137 so that we can actually solve for those challenges before they become manifest through penalties or draconian measures taken by the health plans. So let me tell you a little bit about the soft launch that we've just completed in 2018. And as I mentioned, this was our attempt to see whether we could actually implement a platform that would meet all of the requirements that are laid out in all of the regulations, including SB 137. And I will say, just sort of as a statistic to keep in mind, when it's all said and done, there are nearly 350 separate requirements that apply to Senate Bill 137 alone. So each of those requirements needs to be met in a certain time frame and in a certain way, and then you have the challenges of additional requirements that may be coming through Medicare Advantage and or Medi-Cal or CDI requirements as well. So it is a very big challenge to make sure that all of the boxes are ticked correctly and that the information in those boxes is accurate. I'm really pleased to say one of the things that we tried to do very early on was get some of the larger network model health plans to agree to participate not only in the project overall, but in the soft launch. And I think this is where IHA had particularly unique strengths in relationships because most of the larger health plans and larger provider systems are in fact members or stakeholders or active participants in IHA programs. So that kind of outreach to these organizations was relatively natural for us and has been quite successful. So in the soft launch, we actually got Blue Shield of California, Anthem, and HealthNet to agree to participate. We had other plans that wanted to participate, and we actually had to hold them off until we showed that the soft launch was in fact successful. We were also anxious to include different types of provider organizations, some that had been exposed to this kind of infrastructure and others that hadn't, some that were in Northern California like Hill, others that were more based in Southern California like MedPoint and their partners. We also wanted to include individual and independent physicians and other practitioners because that in fact was going to be one of the most important test cases for whether this would work for them, including whether the portal was accessible and what the challenges would be in smaller practices. So our goal was to actually do something of pretty large scale. This included over 6,000 practicing physicians, so it wasn't small by any means, but we wanted the diversity of participation on both the plan and the provider side so that we knew for sure that it would work. For those of you that are interested in the technology and the platform, it was important to note too that the platform that was used was in fact a fully production capable platform. So it wasn't a technology platform that was designed just for the soft launch. It actually was designed to potentially be usable at scale once the soft launch was completed. So we aren't trying to reinvent it as we go. So here's a bit of the reason why this project exists. These are the baseline statistics from the soft launch, and I will say a couple things. First of all, the numbers are scary. But they're probably not surprising to those of you that work every day delivering care. The numbers are also the reason why this project really needs to exist. So these are only a few of what we found, but they're representative. First of all, when we looked across those 3 plans and those multiple provider groups with over 6,000 practicing physicians, 31% of the providers that should be listed in Health Plans Online Directory were missing across the 3 plans. So first of all, I'd be the first to say that number is a big challenge, and it's also not unique to these particular plans. I think it would be easy to say, well, they're just big and they're the ones that are having the most challenges. In fact, we saw a pretty wide range of performance across the plans, and we also saw that this number was not out of line with other organizations' experience. So what that means is nearly 1 out of every 3 doctors that should be on a health plan list or directory are missing. The other thing that we found was of those that are on the list, over 10% of those should have been removed, and this may be because there was no contract between the health plan and the doctor. It may be because the doctor had moved out of state, or the doctor no longer practiced, or maybe had an action against him or her. What that tells us is there's inaccuracies in both directions, both physicians that should be listed and physicians that shouldn't be listed. And again, that shouldn't be listed may be because the doctor doesn't want to participate in that planned product. The other thing that is not represented on this page, but is really, really important to understand, is with the advent of the ACA and other product design activities that plans have taken on, there is just a proliferation of networks that are tailored, narrow, tiered. So there's a lot of variation in the different product networks, even under the same product name for a health plan. And most of the physicians that we've been working with have really no clue of the complexity of the networks that they're actually signed up for. So one of the educational components of even the soft launch was helping physicians understand just the number of networks that a health plan actually believes they're participating in, which vary by potentially the size of the network, the purchaser client that somebody's working with, the characteristics of the providers in those networks. So there's a lot of complexity now in what networks are being offered at all. Another thing is that 7% of the providers have incorrect information under the really important category of accepting new patients. This, in fact, is sort of the bellwether for a lot of consumers when they select a plan, because they're usually choosing a plan based on the availability of a particular provider, maybe their existing provider, or one that they'd like to select, maybe a specialist, or maybe somebody that they're been referred to. If that is not accurate, then essentially there's a whole cascade of decisions that are made based on incorrect information. And this is just one of the more specific metrics or pieces of information that in the soft launch we found was inaccurate. And remember, that's 7% of the 69% that are left after you take away the providers that are missing. So there's a lot of challenges in the baseline, and I think we all understood that conceptually, but we're actually putting numbers on it so people can see for themselves where they sit versus the industry. Now, a little piece of good news to help you understand the power of the utility. When you get multiple plans and multiple provider groups into the same environment, and you are actually validating or testing the information that you're getting, you can actually do some pretty amazing things. So the blue box represents the accuracy of the information based on MPI number across 3 plans. And this is only possible because we have more than one plan participating, and we have, in this case, 3. So this gives you a little bit of a flavor of what having a common data source platform can allow you to do. And one of the things to point out in this case would be if this number were, say, lower, as it was for some plans versus another, we can then validate which of the right numbers that we're getting is in fact correct. So if people, another example would be if there are different specialty assignments to the same physician, well, if 9 plans believe that the physician is practicing as a cardiologist and the 10th plan believes that he's practicing as a pulmonologist, it's relatively easy to make the judgment that he is probably practicing as a cardiologist and validate that with the 10th plan to see why that field in their data is inaccurate. So there's a unique opportunity here with the Symphony platform to actually make corrections, make updates, improve accuracy simply through the transparency of what we're seeing across multiple trading partners. So let me give you a little bit more detail on how this works, and I apologize if this is kind of getting to the weeds, but I think it's helpful. So this box actually describes just some of the data elements that the platform tracks, and as I mentioned, a lot of the regulatory requirements literally require hundreds of data elements to be tracked. So this is just a handful. Some of them are pretty obvious, like the name, but even something like the physician or provider name can get confusing if somebody uses their middle name or their middle initial. So imagine boarding an airline or filling out a passport. If your name doesn't match exactly, technically you may not be able to get through security. So when you're dealing with multiple plans, 10, 12, people may list the name differently. And you may think that's a fairly trivial thing, but it may actually be how something in an automated system gets rejected because there isn't an exact match. So a lot of what we are doing with the platform is trying to understand how to standardize that as much as possible, and then how to account for what might be very slight differences. In some cases, a middle initial gets a period after it, and in some cases it doesn't. So how do you manage that kind of difference? At the more, I think, substantive level, you could look at phone numbers and whether the phone number is actually at an office location where people are seeing patients, or whether that's a billing office. At the contract level, we talked a little bit about accepting new patient status. So having that be accurate is incredibly important. So even if you get all of the demographic information correct, if the doctor is not accepting new patients, it's very, very important to have that accurate. And he or she may be accepting new patients for some plans and not another. That's another nuance to all of this. So if you start to think about hundreds of data elements that need to be not exactly the same, but need to be validated as accurate, that gives you a start on the kind of data that a health plan, a provider organization, or a small independent practice would be submitting on a regular basis or updating on a regular basis to one source. So the idea here is, rather than every a small practice or provider organization doing this with every health plan trading partner and going back and forth in a variety of different ways. Everybody does it once on behalf of everybody else that needs it, respecting confidentiality and their contractual obligations. Symphony then takes that information in, validates the source information using both third-party validation but also corroboration across the multiple trading partners that are using the platform. Providers then attest to the accuracy of a single profile that they have, and then those weekly reports and notifications are provided back to the plans and the providers so that they can correct things in their systems that don't seem to be accurate. So the power of this, using a term from the technology industry, there is a network effect. The more people that get on the platform, the better it works and the faster it works and the more accurate the source information becomes, so that the updating and the corrections become fewer and fewer as the cycles increase. So let's talk about the benefits of the provider directory. First of all, it's driven by collaboration. So collaboration is probably an overused word. It's a very important word here at IHA, but it really starts with the notion that people can and do want to share information, make it as accurate as possible so that the user of that information is using it with confidence. And one thing we did see in the soft launch that doesn't pop up in the statistics is how willing the providers and health plans involved in the soft launch were to share reasons why things were not accurate and what corrections they would need to make and how difficult it might be in their system to make those kinds of changes. So there wasn't the sense that they needed to hide their challenges. There was a sense that they wanted to, in some ways, expose their challenges so that people could understand the degree of difficulty of the fix or what was involved. And we've seen a lot of that in other work that IHA has done, but it especially came through in the soft launch. Also, there's a huge compliance component, and I talked a lot about that, but the compliance really is in the spirit of how can we make this information most accurate for anything where provider information is critical to the outcome. So the most obvious one is consumers choosing a health plan or choosing a physician or choosing a physician group. But as you may know, IHA is heavily involved in a number of performance measurement activities where the accuracy of the provider as the unit of analysis is really, really important. Our focus historically has been on larger provider groups, but to the extent that anybody is measuring anything, the accuracy of the people being measured is really, really important. So I tend to think about compliance not so much as a kind of a legalistic or regulatory thing, but how are we sure that the information that we're sharing and providing to business partners is actually accurate enough to make decisions on. And then the third area is really the confidence. There's a lot of confidence that comes with knowing that you can do something one time well, and that will be reflected in multiple places, like multiple plan directories. Right now, we're in a state where the confidence is actually very low, and the frustration level tends to be quite high because physicians in particular and their office managers and staff are spending an enormous amount of time and resources updating things that they may have already updated, rechecking things, becoming aware of participation rules that they weren't aware of before. So all of this is meant to say, can we create an environment where we can all do the right thing once and get on with our day and get on with the work that really matters, which is taking care of patients. So part of IHA's motivation and mission is how do we make the administrative side of things a little less painful and also help people to free up the time so they can focus on the things that matter. So at this point, I'd rather than take my word for it exclusively, I'd like to share a video that Dr. Ted Mazur did for us. And Dr. Mazur, many of you may know, is actually a practicing ear, nose, and throat physician in San Diego, and he's the immediate past president of the California Medical Association. So he was actually asked to participate in our soft launch, and he was not at all shy about what we did well and what we could improve. And in the spirit of saying, here's what one practicing physician who has been involved in this thinks, we wanted to share this short video as part of this educational opportunity. I should also say, as a matter of history, CMA was actually a sponsor of the legislation that actually drove the need for the utility. So they are highly vested in its success as we are.
My name is Dr. Ted Mazer. I'm a solo practitioner of head and neck surgery in San Diego, and currently serving as the president of the California Medical Association. We're now required on a regular basis to certify that we are participating with a plan. So the plan X sends us a form in the next month, plan Y sends us a form, and somebody's got to fill those forms out. Hopefully with the Symphony Provider Directory, all of that after front-loading the information will be much simpler, much more efficient for offices. It should be a big time saver, work saver, if it's done accurately. Sometimes you have to do a little work up front to save yourself time down the road. And the benefits of doing that work up front will come back and really reward you and make your life and your staff's life simpler. If we get there, we orchestrate an ability to have accurate information on a timely basis. Everybody wins.
So I hope that we've achieved the learning objectives for today's session. We would love to answer further questions or explain things further. If you haven't heard what you need to hear on this webcast, there's some information here for you if you'd like to contact us, and I assure you this is going to a live person. It's not a box that we sometimes look at. And we are at a critical stage for Symphony. We really, really need everybody to take a risk a little bit and join the party, if you will, and help us make it work, because we've got a lot of momentum through the health plans and the larger provider organizations and actually the independent physicians that we've worked with, but we also need to continue to get the word out and why it's so important to get to critical mass in 2019. So thank you very much for your time and attention.